Rose Knapp, Professor of Pharmacology and Nursing at Monmouth University School of Nursing, and an acute care nurse practitioner. I'm very much committed to this topic because I am a prescriber of many medications for the older adult and see a compelling issue with polypharmacy and over-medication in the older adult. And I feel that this is very important for all healthcare providers to be aware and also to address this issue. This module is an online module of the Consortium of New York Geriatric Education Center, developed by the Hartford Institute of Geriatric Nursing and the New York University College of Nursing. The consortium is a consortium of 4 academic partners committed to training a wide range of health and human service professionals and interdisciplinary faculty throughout the state of New York. The objectives of this module will be to cover and discuss the specific needs of the older adult patient, describe the variables when choosing medications for the older adult, discuss the causes and prevention of polypharmacy, discuss the Joint Commission recommendation and the medication reconciliation process, and also discuss the Beers criteria, its application to medication regime of the older adult. Statistically, drugs in the older adult are disproportionately high. Patients over 65 constitute about 12% of the population. However, they consume about 31% of drugs, secondary to the number of reasons. There's an increased severity of chronic illnesses, particularly chronic obstructive pulmonary disease, diabetes, heart disease, and as people age, they have more propensity to have these chronic illnesses. They have multiple pathologies which require a great deal and complex drug regime, and also excessive prescribing, which actually can be attributed to multiple prescribers, which will be discussed further in the module. The specific challenges of therapeutically prescribing for the older adult is that principally they have altered pharmacokinetics, which is the action of the drugs have on the body. And they have multiple and severe illnesses which actually affect drug metabolism and drug excretions. Many of the drugs that older adult patients are on are not known to all the prescribers, and there's not really a mechanism for determining exactly the medications that a particular older adult patient is on. And poor adherence. We will discuss the difference between compliance and adherence, but there are definitely contributing factors to why patients do not adhere to their drug regimes that are prescribed by the providers. In terms of how the body physiologically changes that affect how the older adult utilizes medication, is that as we age, the ability to absorb drugs. The thinking in pharmacology is actually to have the highest benefits with the lowest risks, and actually to have the drug be absorbed into the system, be metabolized and distributed to the area that it's going to be effective, and then be excreted without any untoward effects. In the older adult, absorption is affected because as we age, the pH or the acidity of our gastric contents actually increase. And many medications need the acid of the gastric contents to be able to break down and absorb the drugs. The abdominal area intestinal area has a decreased absorptive surface area. And also because of decreased gastric motility, medications stay in the body more quickly for a longer time, and are not readily sent to the area of distribution. So there's decreased gastric motility and delayed gastric emptying, which has a lot to do with just normal physiological aging. We have to compound this if you have patients who are diabetics. Diabetic patients also have decreased gastric motility, so you have an added contributing factor of why these medications are not absorbed properly. Again, just to address that, most medications are given orally, so the stomach is very important, and the gastric contents are very important for medications to be absorbed properly. Quite often we see patients being given medications that are enteric-coated or sustained release, and they're given and crushed up, and that actually pharmacologically affects the medication and how it is absorbed. In terms of distribution, the pharmacological intent is to get the medication to the area that it needs to be distributed to, the area where the cellular properties are, there's some abnormality or malfunction. So you want to have the medications absorbed in the abdomen, preferably, and then distributed through the bloodstream to the area of action. Problems with the older adult is that they have increased body fat. Many people think that as people age, people get thinner, but actually people develop more body fat, truncal fat. Extremities get leaner, but the actual truncal obesity increases, which the fact is in pharmacology that fat actually holds on to medications. So it actually doesn't get to the site of distribution, it actually sits in the fat cells, which is a very important thing when you give somebody anesthesia. An obese patient who's given anesthesia has to be really, really monitored much more closely, because the anesthesia sometimes stays in the tissue, the fat cells, much longer. As we get older, we have a decreased lean muscle mass. Muscles actually do help with distribution. So if you have a less defined muscle mass, you have less you have impaired distribution to the site of pharmacological process. Also with muscle mass, we have to think of the heart. Our heart is a muscle that actually is going to be pumping blood to the site of distribution. So if our heart is not an efficient muscle, it will also affect how well the medication gets to the site of action. Our serum albumin is very important because many medications are protein bound. They need a protein molecule to be able to bind to them, to be able to be active. Quite often in older adults is that they don't get enough protein intake because of the expense of protein, which are mostly meat sources, and a lot of times they have low protein, which will exacerbate and prevent that distribution of the linking of the drug molecule to the albumin. If a medication does not link to albumin, then you have free medication circulating in the bloodstream, so people have the toxic level of a drug, but they don't have the therapeutic effect of the drug. So having a serum protein is very, very important for distribution of drugs. As we discussed about the heart muscle, is that if we have a decreased cardiac output, if our circulatory system cannot pump or distribute the medication through the bloodstream, because the heart is not an efficient pump to get the blood to the small tissues, particularly like the lower extremities, then the medication is not going to be distributed properly. Also, older adults have a decreased body water, which precipitates a possibility of having more particles of the drug as opposed to it being properly diluted in the system. So it also predisposes the person to toxicity. In terms of metabolism, the one organ that you think about that metabolizes drugs is your liver. The liver has a propensity to actually take very toxic drugs, and before it is even absorbed or distributed, can actually take the medication and break it down prior to it getting to the rest of the stomach through the portal system, and which will actually dilute the amount of the medication. So medications that have a high, what's called first pass effect, the dosaging has to be properly increased sometimes, because the liver will take the drug prior to it actually getting to the site of distribution. This isn't really an issue with the older adult. What we see in the older adult is as we get older, this is normal physiological aging, that we have decreased blood flow to our liver. Our liver itself actually gets smaller in size, and the enzymes that help actually metabolize the end product of the medication, actually there's decreased activity. What we actually want the medication, the liver to do, is break down and metabolize the end products of the drug after it's actually been used at the site of action. So if you have a poor portal system or a poor liver, you can have an increased level of the drug remaining in the body because it's not broken down properly. The last organ that is very important and that affects the excretion of medications after they've been absorbed, been distributed, perform their physiological action at the site of the cellular disturbance. Then after the liver breaks it down for metabolism, the kidneys are required to excrete the end products of medication. We see this very often in particular medications that are called or termed nephrotoxic. Medications such as vancomycin and the aminoglycosides like gentamicin and tobramycin are very, very nephrotoxic. So particularly in the older adult population, because they have a decreased blood flow, because their vasculature has become somewhat sclerotic just from getting age, the glomeruli do not filtrate as properly as they used to. The tubules don't secrete as much, and the number of actual nephrons, which are the active cells of the kidneys, there are actually a decreased number of nephrons. We have to compile that with giving nephrotoxic drug. So we have an organ that's actually compromised just from normal physiological aging, and then you give nephrotoxic drugs. So it's very, very important in many patients that you are checking their BUN and creatinine and their glomerular filtration rate prior to giving these medications. So pharmacodynamics is how the medications actually work on the body. We discussed how the body, actually physiological changes we age affects the absorption, distribution, metabolism, and excretion. But we also have issues where once we get the medication to the site of action, there are some medications because of age that older adults are predisposed to actually having some issues with how the medication works. One of them is increased drug sensitivity. As we age, our immune system is changed, so we are actually more sensitive to drugs, which predisposes us more to adverse drug reaction. Changes in the blood-brain barrier. Our blood-brain barrier is, as we mature, actually is responsible for not allowing medications to go into the central nervous system. We have this in childhood. As we age, the blood-brain barrier is it's very strong. As we age, there's a decrease in that blood-brain barrier. So we worry about medications that cross the blood-brain barrier that get into the central nervous system, which can cause a lot of neurological central nervous system depression. Some of the receptors are required for drug metabolism. We talked about protein. There's also norepinephrine. There's a protein called CD450, which helps modulate, if drugs are high in CD450, they can cause many drug-drug interactions. As we age, that alteration is there, and we're more predisposed to adverse drug reactions. The increased drug reaction in the older adult also is because of these contributing factors we just discussed, but another contributing factor is that we are on many, many medications that many prescribers don't know, and there's a lot of drug-food, over-the-counter drug interactions. Adverse drug reactions, let me just back up a bit, is that all medications have a side effect. We're dealing with altering chemistry. So every medication that any person takes, be it an over-the-counter, be it an herbal, has a side effect. A side effect can be nausea, vomiting, diarrhea, can be a yeast infection. There's no medication that does not have a side effect. What we're mostly discussing are adverse drug reactions that can cause very serious issues, particularly in the older adult. Adverse drug reactions are 7 times more common in the older adult and account for 16% of hospital admissions and 50% of medication-related deaths. That's why I think that I am so committed to this. Many times I have patients come in to the emergency room and we'll ask them what medications they're on, and they'll actually just give us a brown paper bag, and I'm sure many of you can relate to that, where they have no list of their medications. And when you start going through the medication list, they actually will tell you that they're no longer on the medication. The other issue is that there are multiple prescribers who are not aware of everything that the patient's on. And this is a very, very, very serious healthcare crisis that really, really needs to be addressed. And no matter what your discipline is, it's really important that if you work with people at home, if you work with them in physical therapy, as a pharmacist, as a nurse, as a physician, it's very, very important that you are aware of the medications that the person's on. And even if also important to whoever their significant others are, whether they have family members, it's very, very important. Because also remember that we're dealing with people who might have some form of dementia, so that makes it even more compounded. The factors that predispose older adults to these adverse drug reaction, as I mentioned before, is drug accumulation, secondary, particularly to reduce renal function. The polypharmacy, people are on multiple drugs that interact. The greater use of drugs that are low therapeutic index. What a therapeutic index is that I discussed earlier that in pharmacology or as a prescriber, your goal is to actually give something that the benefits outweigh the risks. So you would want to have more benefits and less risks. The closer that index gets to where the benefits and risks equal each other, that's a low therapeutic index, and there's more chance of having adverse side effects. An example of that is digoxin. Digoxin is a drug that's used quite often for heart failure, but it has many, many adverse effects, and we'll discuss that actually later in our case study. An example of a low therapeutic index would be if you had to give chemotherapy to somebody. Chemotherapy is a poison, so the benefits and risks might be equal to each other, but the more emergent that something is, that sometimes you have to give things that are actually of a low therapeutic index, but you have to be aware of the possible adverse effects. Inadequate supervision of long-term therapy. One of the things that the literature mentions is that it's not often enough are medications reviewed. We will talk about medication reconciliation later on in the module. However, many times providers do not go over all the medication that the person's on, and sometimes it really needs to periodically be reviewed and supervised. And poor patient adherence, and adherence means is that the patient does not have a buy-in to the therapeutic regime. And a lot of times it's because there are many, many reasons why patients do not adhere to the regime. Either there are adverse effects that they can't tolerate, there's economic reasons, they don't understand why they're on it. So it's very, very important that this adherence as providers or family members even really have people understand why they're on the particular medication. So factors that attribute to poor drug adherence in the older adult is, as we discussed before, multiple chronic disorders. If a person has diabetes, heart disease, heart failure, chronic obstructive pulmonary disease, and thyroid disease, that's 5 chronic disorders that have to be managed at the same time. As a result of that, with the way the present provider environment is that people go to multiple prescribers. They go to multiple specialists. So if your patient is a diabetic, they're going to go to an endocrinologist. Your patient with the heart disease and the hypertension and the CHF will be going to a cardiologist. As a result of that, sometimes providers don't know every medication that the person's on. So it's very, very important. I think the onus really is on the primary care provider to be able to pull that all in so the patient is aware and all providers are aware. One thing that actually is going to be addressed, and this is not a political statement, but in the Affordable Care Act, one of the things that is really one of the goals is to actually institute electronic medical records where every provider who the patient sees will have access to every medication and all of the person's medical records. So it would be more of a comprehensive history of the patient and also treatment regime of what's going on. Many practices, as our practice does, we use electronic health records, and we do have templates, and we are able to see the medication. However, there are pitfalls to that, and it is user friendly, and people have to program the patient's history and medications. But we are starting to do that because they found that the cost is astronomical. If you look at that 50% of medication hospitalizations in the older adult, medication problems attribute to the hospitalizations, it's something that really is pervasive and needs to be looked at. The other issue is that in terms of primary care providers, the decreasing number of primary care providers in our society has really made this difficult. Last year, statistically, only 1% to 2% of medical school graduates have decided to go into primary care. It just is not lucrative enough, and that's where there is a serious gap. The Institute of Medicine has agreed to have nurse practitioners, advanced practice nurses, fill this void, and also the government is trying to provide some funding and education for people to go into primary care, because really the primary care provider is the manager. I had a patient once who came to me who had seen multiple providers and got multiple opinions, and very intelligent older gentleman, and he came with his, never had been sick ever before, and he came with his medical records and said to me, "I need a manager." And I really feel that he really was on the mark, that a lot of people do need a manager who's going to pull this all together. Because of multiple prescribers, we have multiple prescriptions. Patients quite often go to multiple pharmacies who fill the same prescription. If you have somebody who has dementia as a patient, they forget where they filled their prescription, and sometimes they go to more than one pharmacist. Another thing that's being addressed is e-prescribing. E-prescribing is where providers, and I use this quite often in my practice, where you can actually electronically send the prescription to the pharmacy. It has its pitfalls. It has its advantages. The good thing is that there's less issues with writing errors with medications. Also, pharmacists can track the medication more readily. There is not a actual universal system where all pharmacies can cross-check. We do recommend in our practice that patients use the same pharmacy, or at least the same company, like I'm not advertising, but like a CVS or a Walgreens, and not jump from different types of pharmacies, because they can actually electronically check within a system in the nation whether somebody's medications are on. Multiple dosages. It's very, very difficult, particularly if you're somebody who has any cognitive impairment, to remember if you took your medication, if it's more than once a day or multiple times a day. So that makes it very, very confusing. Anytime a patient goes into the emergency room, I have this happen with a lot of patients in my practice, they'll go into the emergency room or they'll go into the hospital, and their whole drug regime will be thrown off. And then if they're confused and they're already on 2 blood pressure medications and the hospital puts them on a 3rd, they don't realize that they should have stopped the other 2, and they're on 3 blood pressure medications, which causes them to have hypotension. So it's really, really important that anytime you change somebody's drug regime, that there's some review with that. Again, I talked about cognitive impairment. One of the things that can help people is one of the little drug cases, the daily drug little organizers, which makes it much more helpful to people with cognitive impairment. It isn't just the older adult that have that problem. I know quite often many people say to me, "I'm not sure if I took that medication or not." The other thing that goes with that is physical impairment. If somebody has arthritis, has difficulty opening up medications, cutting medication in half, measuring medication. In the diabetic patient, they actually have changed the way insulin's given to make it more readily accessible for a diabetic to give an injection. A lot of the diabetes medications, as many of you might be familiar, are given in pens now, where the dose is already preset, so it makes it much more easy for them to give to themselves. Living alone, it's very, very prevalent in the older adults, particularly in the women over the age of 85 are the highest population that live alone. And quite often there needs to be somebody to make sure that that person is indeed taking their medication. I mentioned about recent hospital discharge, and I'm going to go into that a little bit more when we go through medication reconciliation. One of the biggest things is the inability to pay for medications. Some older adults pay up to $1,000 a month for medication. There are some plans where they can actually help, some states actually help patients with low-income seniors who need help with their medication, but unless they're aware of it, it's very, very difficult. So quite often what we see is patients, if you have two spouses and they're both on the same medication, they'll alternate the medication so the medication spreads out twice as long. However, it's not efficacious. They're not taking the medication as it should be. So one thing about as a provider, it's very, very important that when you prescribe medication, that you make sure it's affordable and help the patient to maybe get some help with their medications. The presence of side effects, particularly with older adults, I would say one medication in particular would be diuretics, water pills. Many times people are embarrassed because they might be incontinent, so they don't take their water pills. If they want to, or if they're going to their club, their senior club that day, they want to very, very cautious about taking the subway or traveling and having an accident. The other issue, though, you've got to also deal with as a provider, so you've got to determine which is the best time to take it, because you also have to think of the older adult who will take it in the middle of the night and get up to go to the bathroom and have a fall. So the side effects should be explained, and it should be also determined which works best for the patient to be able to take their medication. And that's where the term adherence comes in. That's where the patient actually has an active say in when they're going to take the medication. They need to know why they need to take it, and then it is up to the provider to determine when the best time to take it. Back in 2005, Beers, who is a well-known gerontologist, made the definition polypharmacy. And polypharmacy was defined by Beers as taking medications at the same time. So a patient being on many medications all at the same time. The issue is that there were very many adverse effects. And what the Beers criteria actually determined, because of the evidence that they looked at, is that average person over 65 statistically takes 4.5 prescription medications at a time, plus 2 over-the-counter medications. That's 6.5 average medications in a day, different types of medication. So as a result of that, backing up, is that Beers and his colleagues decided to make a list for providers that would be a kind of a yellow to red flag of medications that really should be given with caution in the older adult. This is from a quote from Love in the Time of Cholera, and I thought this really is a very good depiction of how we are in our society, that we kind of use medications to balance out medication. So he rose at the crack of dawn when he began his secret medicine. Bromides to raise the spirits, salicylates for the aches in his bones when it rained, ergosterol for vertigo, belladonna for sound sleep. But in his pocket he always carried a little pad of camphor that he inhaled deeply when no one was watching, to calm his fear of so many medications mixed together. So I think we're all pretty guilty of that, where we take a medication to overcome a medication. And I think that it is so very dangerous, and it's something that we really, really need to get a better hold of. So medication appropriateness is the overuse of medication. 3 types of medication in our healthcare provider environment that are used way too much or overused. One is antibiotics. We deal with patients all the time as an emergency room provider and a primary care provider, where people want to come in and want to get an antibiotic for every upper respiratory or sore throat or whatever. The issue for that is that, and particularly on the other end of the spectrum, not the older adult, but the American Pediatric Society actually came out and said that it's really not efficacious or helpful to give antibiotics when they're not indicated, particularly in children. And some of the cases are otitis media in children. In the adult population, it's sinuses. Not all sinusitis require antibiotics. Particularly in our older adult population, because they have a decreased immunity, their immune system is not as strong as it used to be. If we keep giving antibiotics, not only do we have mutations of bacteria, but we also have, it's very difficult for them when they actually do indeed have an infection, because their body cannot build up immunity toward this bacteria. So most practitioners are guilty of, at times, of giving an antibiotic without actually examining the patient and over the phone, or just because the patient asks for it. And as a provider, I will say that it's very, very difficult sometimes when people who have waited particularly 4 hours in the emergency room to see you, and then you tell them that they don't have a bacterial infection based on your evaluation. But it's very, very important that people don't get too many antibiotics, particularly, again, in the elderly. If we go back to that renal problem, we don't want to give them nephrotoxic medications. Some of the newer medications that are given quite pervasively are like Levaquin. Levaquin, you really need to know the person's renal function before you give it. It's a very broad spectrum antibiotic. It's very nice to give because it covers a lot of bacteria, gram-negative and gram-positive. It's only once a day, but however, in older adults, the renal function must be checked first. The other ones are GI medications or stomach medications. Most medications, particularly the antacids like Mylanta, Maalox, Tums, shouldn't just be given or taken over the counter by patients because they do two things. One, they might mask the symptoms of an actual heart attack, because many times people have GI symptoms where they have indigestion and they're actually having a heart attack, or they neutralize medications. We talked about that pH, that we needed the acid of medications for them to work, and all antacids neutralize that. So again, those medications stay in the system and are not absorbed readily. And then particularly in the older adult population are sleep medications. We want to be very, very careful of any medications that are going to decrease the central nervous system or cause any dizziness, lightheadedness, because the older adults, if they get up too quickly, they could have a syncopal episode and they can actually fall, have risk for fall. Their risk for fall as it is because their gait and mobility is probably sometimes compromised. And then if you add a sleep medication, many sleep medications cause amnesia, so they've got to be really, really carefully given. Misuse is another issue, is that many times providers see that people are given the wrong dosage of medication. They're given either too high a dose or not the adequate dose to be able to effectively be therapeutic. So it's very, very important, and it's actually a problem that's seen quite often. People need to be taking the medication as advised by the drug companies, and they should be given as they are actually recommended. However, let me just qualify that, is that it's very important that with the older adult that you start slow and go up. You always, with the older adult, give the lowest dose possible when you start any medication regime. You don't start at a high dosage level. You start low, and it's actually the saying is start slow and then go up slowly. Underuse and chronic disease, the two diseases that I would say that are very, very important, particularly in the older adult population, is in diabetes. Many of our older adults who are diabetic, particularly type 2 diabetes, adult onset, are not having their A1C levels properly adjusted. So they have tremendous comorbidities of renal disease, peripheral neuropathies, macular degeneration, and it's very, very important that the A1C is kept within a therapeutic dose. The other disease I would say that a lot of patients have are not properly monitored would be in asthma and COPD. The American Thoracic Society really has presented a step approach to people with COPD and asthma, and quite often people are just given medications that are just going to relieve short-term symptoms, but really they need to be on medications for a long time. And the last thing about underuse in the older adult is preventative medications. Very important that the older adult population get their yearly flu vaccine, their Pneumovax for strep pneumonia, which is the prevalent pneumonia in the over 65 population, and people over 60 should get the Zovirax vaccine for herpes zoster. Herpes zoster is very prevalent, and also people have a secondary side effect with that where they have terrible neuropathies from it, post-herpetic neuropathy. So it is very much recommended that primary care providers give the Zostrix vaccine. So back to the Beers criteria, just an overview is that the purpose of the Beers criteria is to reduce medication-related risk, to increase nursing awareness of high-risk drugs, to monitor adverse effects, and it facilitated collaboration of multiple healthcare providers, mostly gerontologists, social workers, pharmacists. They all collaborated together to be able to look at this issue with medication-related risks and to be able to decrease adverse effects. So the tool is actually on the John Hartford Consult RN website, which I think we will have for you. And you can actually look at the tool. And the tool identifies medications that have potential risks that outweigh benefits, particularly universally appropriate to people over the age of 65. It provides a rating scale of severity for adverse outcomes and provides a descriptive summary associated with education. The Beers criteria, if you look at the medications that are there, very important are a lot of narcotic opiate pain medications, or a lot of antipsychotic medications, or a lot of cardiovascular medications. So it actually is a guide to drugs that should be like a red flag or a potential outliers for risk for adverse drug reactions. The strengths, as I said before, is it was developed by 6 nationally known experts in geriatric care and pharmacology. It's a widely used screening for populations for possible drug-related problems. The only issue is that it doesn't identify all potentially inappropriate prescribing, all cases, and it isn't a substitute for professional judgment. You have to actually look as the provider of whether it would be appropriate. I know I take care of many 65-year-olds where some of these medications would be with their cognition and their level of function and their ability to meet all their daily needs every day, they would be okay with taking this medication. Again, it's a tool to be able to help nurses particularly look at medications that might potentially be adverse and cause problems in the older adult population. Another thing that is being utilized to help address this problem is medication reconciliation. Medication reconciliation is defined as the process of comparing a patient's medication orders to all medications that the patient's taking. Now, it sounds very, very common sense and very logical. However, this is not routinely done. And a lot of institutions have started doing this, but not universally and not maybe effectively, and we'll discuss that in a minute. The goal of the medication reconciliation would be to avoid any omissions in medication or meeting the patient's needs based on their comorbidities, duplication of medications, making sure the proper dosaging is there, to avoid any errors in medication, and to avoid any drug-drug interactions particularly. So the 5-step process would be, and I know many of you, I know I've spoken to many providers, particularly in long-term care, seems to do a very good job at this, is that many of you do this. Unfortunately, not all acute care facilities do this. The 5-step process would be to list the patient's medications, develop a list of medications that need to be prescribed, and then compare the two. Again, this is ideally would be for people who are not in the outpatient setting, but usually in the acute care or long-term setting. Then make a clinical decision based on the comparison of the two lists, and then communicate this list to the appropriate caregivers and the patient. So then the patient would be discharged on the correct medications after both lists were reviewed. In 2005, the Joint Commission, in their patient safety goal number 8, felt that all medications should be accurately and completely reconciled across a continuum. Their goal further in 2006 was to implement a process for obtaining and documenting a complete list of the patient's medication. A complete list of the medication is communicated to all providers. And then they also qualified it, thinking that if the patient is unable to participate in this reconciliation, such as your older adults with a dementia, that there's an authorized person involved in the process in all interfaces of the care from admission to discharge from the facility. So assuring that there's somebody else who's there as the advocate for the patient to help this process be run smoothly and make sure the patient's on the right medications when they leave. The Joint Commission further recommended that the medication list is highly visible, located in the patient's chart, create a process of reconciling medications at all interfaces of care, so all consultants, the pharmacists, social work, physical therapist, everybody knows about these medications, that they're reconciled, and on discharge, you would provide the patient with a complete list of medications. Unfortunately, to date, this isn't always being done very thoroughly with patients. I personally had a patient who was discharged from a facility in New York City, and she was a post-CVA patient who did have mild dementia, and she was discharged via ambulance to her home, which she lives alone. When I called her to follow up to find out when she was supposed to follow up with the vascular surgeon that she saw, she informed me that she never received any discharge instructions nor a medication reconciliation. And it got somehow in the process of discharging her through the ambulance, she never received the follow-up. I also had another patient who was on Coumadin, a blood thinner, and was discharged on vitamin K prescription. As for those of you who do prescribe and know about Coumadin and vitamin K is the antidote for Coumadin, but most people are not given Coumadin unless their coagulopathies are way, way beyond the normal range. The usual practice is just to hold the Coumadin, so that was not a very good medication reconciliation for that patient. Plus, if that patient had filled the vitamin K prescription, it was really not cost effective because they would never be giving it. So we have a while to go with it. In my discussing it with many providers, long-term care is doing a much better job than acute care at this point. So how do we prevent adverse drug reactions? And some of the things we discussed, I just wanted to touch base on a couple of other things, is that we need to get a complete drug history from a patient. And very important, or their significant other or their family member, which includes over-the-counter and herbals. Many herbal medications do interact with prescription and over-the-counter medications. So you need to ask people. And the other thing we need to get from people is their allergies and what kind of reaction they had to the medications. We need to account for those pharmacokinetic physiological changes as we age, and also which would have to do with absorption, distribution, metabolism, and excretion. And then we also have to bear into mind the pharmacodynamics of the changes that occur with aging, how the body utilizes the medication. As previously discussed, it's very important to initiate therapy with low doses and monitor the clinical response and plasma drug levels if indicated. it's very, very important that if you're going to start somebody on any medication, that it's very important that you at some point evaluate whether there is a response. And some medications, particularly as I mentioned before, digoxin does have drug levels. And medications, particularly that are protein bound, really it's very important that you get drug levels if they're indicated. Employ the simplest regime possible. The medications that are given once a day with a daily drug container really helps the person to be more compliant. Monitor for any drug-drug interactions, particularly an example would be taking antacids with a medication and then the medication doesn't work. Periodically review the drug regime, which has to do with also monitoring the clinical response. If the person's not getting a good clinical response from the medication, then it really needs to be changed. Quite often I take care of patients who come into the emergency room who will tell me that their blood pressure is always in a very, very high level. And that is not therapeutic. It really needs to be reevaluated. So we encourage them to go back to their primary care provider to have their medications reevaluated. Periodically, so we're going to review our drug routine, and then we want to encourage patients to dispose of old medications. Medications change, their chemical makeup changes, and this also includes over-the-counter medications. I know quite often I go to family member's house and I'll go to take Tylenol and it's 4 years expired. It should not be there. It should be discarded. And then to promote adherence to drug regime is really to have the patient be, or if they do have any level of dementia, and their family member be an active participant in their drug regime and why we are doing what they're, why are they on the medication, what to look for, what adverse effects they're going to have, and how to deal with that on a daily basis. And to also have an open communication with the patient. We talked about simplifying the regime, clearly explain why it is, label the containers clearly. A calendar, diary, or pill counter is very important. Assure their access to a pharmacy. It's very important. I know as a provider, many times I call the pharmacies and I have an ongoing dialogue with them to find out what the patient's been on and what they've renewed. And it really helps me a lot because they need to know, and that goes back to also using the same pharmacy. It's very, very it's not therapeutic, and it's not helpful if patients use multiple pharmacies. Assess the affordability of medication. I always tell this story to my nurse practitioner students. I remember the first time I wrote a prescription for an antibiotic, and I was so proud of myself. This patient was allergic to penicillin, and they had a dental problem, and I gave them a medication, clindamycin, and they left, and about 20 minutes later, the pharmacy was on the phone, and I thought, oh my gosh, what did I forget? Did I not put my DEA number? And the pharmacist said to me, did you realize that this medication is $163 and this person has no insurance? So that was my learning curve, and as a provider and as a prescriber, I always make sure that, and that goes back to adherence, it has to be realistic. We can prescribe anything for anybody, but the importance that the patient has a buy-in to why they're on it and that they can physically afford the medication. It's very, very important. Involve a family member or friend, particularly in those older adults who live alone. And again, monitor the therapeutic responses, adverse effects, and plasma drug levels on a continuing basis. So I'm going to finish up with discussing a case study. This is a very, very interesting case study that could be really applicable to many of the patients that many of us see, and no matter what our discipline is. Mrs. A is a 71-year-old widow with congestive heart failure and osteoarthritis, who has recently been exhibiting quite unusual behavior. Her daughter is concerned about her mother's ability to remain independent and wishes to pursue nursing home admission arrangements. She fears the development of a dementing illness. Over the last 2 to 3 months, Mrs. A has been confused, easily fatigued, and very irritable. She has developed disturbing obsessive-compulsive behavior, constantly complaining that her lace curtains were dirty and required frequent washing. Detailed questioning revealed that she thought they were yellow, green, and possibly moldy. The medications that she's on is for the heart failure. She's on the furosemide, which is known to people who are non-prescribers as Lasix. She takes that in the morning. Digoxin, which is also for her heart, for her contractility, for her heart muscle. Acetaminophen, 500 milligrams, which is Tylenol, 1 to 2 tablets. She takes every 4 hours for joint pain. And Mylanta for 20 milliliters as needed for heartburn. One thing to think about is, are any of these medications attributed to her present condition, and why? Do any of these medications interact with each other? Is there anything problematic about her drug management? And what further information would you need to know? In answering these questions is that, one of the things is that, well, we'll look at the medications in our next couple of slides, and we can see, actually, let's look at these side effects of the medications, and we'll see that they do attribute to her present condition. Furosemide, the dose is adequate, and it's indicated for decreasing edema and fluid because of her heart failure. It predisposes adverse effect is low potassium, and consideration is that low potassium can cause fatigue, muscle weakness, and cramping, which our patient has all of those symptoms. There is a drug-drug reaction with the digoxin. For digoxin to work, it needs an adequate potassium, because digoxin works on the sodium potassiumase pump in the heart. And if you don't have enough potassium for the digoxin to link with, the person becomes digoxin toxic. So that's why for people who work in the hospital, you'll see quite often digoxin is given in the afternoon. And the reason why it's given in the afternoon is that you wait for the person's serum potassium. If the person has a low potassium, you might hold on their digoxin. You also might get a digoxin level to see if they're digitoxic. So one information that's missing is that we don't know if this person's on any potassium supplement and whether she knows about foods that are high in potassium, which would be bananas, oranges, apricots. Is she getting enough potassium? Because she does have signs that fatigue, muscle weakness, and cramping can be attributed because of the furosemide. In terms of the digoxin, early signs of digoxin toxicity is weakness, anorexia, stomach distress. Well, she doesn't have any of that, but look at the late signs: confusion, visual color disturbances, thus the yellow curtains. She thinks her curtains are yellow because she's probably digoxin toxic. It can also cause arrhythmias and headache, which she doesn't have, but the confusion and visual changes could definitely be attributed to the digoxin. So what we need to know is what her baseline vital signs are. Most people who are on digoxin should be taught how to take their heart rate. We don't know if she knows how to take that. We don't know what her last digoxin or potassium level. And Mylanta actually decreases the effect of the digoxin. So she's also taking Mylanta. So all of these drugs are all interacting with each other. And these are very common medications, and that's why I chose them for the case study. In looking at Tylenol, the thing about the Tylenol, there's two things about the Tylenol that I'd be a little concerned about, is that the dosage she's taking, the 500, 2 tablets every 4 hours, is 4,000 milligrams of Tylenol. That's a very, very high dose for somebody of an elderly person. So it could actually be causing liver damage. So we need to know what her liver enzymes are and maybe ask her to decrease the dose and the frequency. Also evaluate her pain. Why does she have the amount of pain that she does? And when was it last evaluated? When was her last bone density? And that really needs to be looked at. So the Tylenol dose is actually too high. And lastly, the Mylanta. When somebody takes Mylanta, it's usually for some kind of heartburn or GI distress. And what I said earlier in the program is that we don't know why she's taking the Mylanta. So I would like to I would think one would pursue why the person's taking an antacid all the time. Is it cardiac related? Do they have reflux? Why is she taking it and for how long? And if you look at the side effects of the aluminum, which is the Maalox, causes constipation, and magnesium causes diarrhea. The magnesium-based medication also causes renal disease, so it can alter the absorption of many drugs and also can cause a potential adverse reaction with the DIG. So those 4 medications that she's on are very, very common, but they all are acting with each other. So she actually is a victim of polypharmacy. The DIG dose is causing digoxin toxicity, which is why she's having the visual changes and the confusion. The Mylanta is interacting with the DIG, which would be changing the digoxin level. And the Lasix and the DIG are interacting, and as a result of that, the patient might be having a low potassium and a high DIG level. So she needs to be supplementing her potassium for the loss of fluid with the Lasix, and she needs to have her potassium checked and her DIG level checked. So she really doesn't need to be going into an institution. She really needs to get to a primary care provider to be able to look at all these medications and how they're reacting with each other. Again, it goes back to education. Maybe she didn't know about potassium with the Lasix and the relationship of the 2 medications and what to look for the digoxin, because the daughter might know why, about the color change, that's a side effect of adverse effect of digoxin. So when we make our decision, in concluding, is that we want to make sure we assess the person, get a very, very extensive drug history of all the medications that they're on. Maybe pick up any adverse drug reactions and find that they are actually having a drug-drug reaction. Plan on either having a provider or whoever is managing their medications do a medication reconciliation to be able to plan on what to do and what to look for adverse effects. Have the medications changed or adjusted. Teach the patient and their family members or significant others of what to look for, and always evaluate the medication regime on a continuum, that it actually is therapeutic. We don't want people on medications that they've been on for a long time and they're not therapeutic, particularly in the older adult population who cannot metabolize or excrete medications as the younger adult population can do. So remember that individual drug therapy in the older adult is essential. I basically mentioned a little bit about adherence throughout the program. Compliance is defined as a provider, no matter what your discipline is, you tell somebody to do something. The chance of somebody being compliant is very, very low because they don't understand why they have to take it. We have a very savvy patient population now. A lot of it has to do with the internet. A lot of it has to do with people going online and looking up things, which is advantageous to a degree. However, I very often tell my patients it's very important that you look at credible sites. So as a result, people do ask about their medication regime and why they're on things. But what we want as providers, people to be adherent. We want them to have a buy-in to why they're on the medication, what to look for as side effects and adverse effects, particularly like in that Lasix case study, knowing about eating potassium-rich foods, knowing about the relationship of digoxin and Lasix, knowing that Mylanta is going to decrease the effect of your medications, finding out why the patient was on Mylanta, knowing that taking that much Tylenol, which is people think very benign, can actually affect the liver. So very important in that by patient education and collaboration with the patient and their caregiver, particularly if they have dementia, really facilitates adherence, and then also collaborating with other providers and the pharmacy. So remember that, I guess the statistic that's really kind of disheartening is that 70% of non-adherence is intentional. So we have to look at the reasons why people aren't adherent, and we want to decrease the amount of hospitalizations and adverse drug reactions. There is a list of references here, and we would ask that you also go on our website for any additional references. And I thank you very much.